The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everyone. Welcome. Glad you're here. I look forward to speaking with you today about a very interesting topic, which is joint noises. We're here to talk about TMD Demystified, and my mission in life is to demystify this problem. If you note my voice is a little throaty today, it's because I'm just recovering from a little cold. I feel pretty good. But excuse the audio if I'm not quite as clear as I might be at other times. This is really an important topic, and it sounds maybe like it's not, or it's so common that everybody knows about TMJ joint noises. Well, the fact is, almost nobody knows about joint noises. But there is data on it, there is experience on it, and there is a lot of misinformation. So this is the second episode in a series that I'm constructing on fact-checking TMD, TMJ. And again, today's topic is joint noises, because there is a lot of misunderstood, crazy stuff, misinformation, the common catchword, and for various reasons. I mean, everybody has their own reasons for doing and knowing and saying what they say and know and study. But joint noises is very, very important. So we're going to divide it into several categories here, and I think that it will make more sense to you as I describe these categories and describe the effect and the knowledge we have about joint noises in each category. So the categories are regarding TMD joint noises, what the patients think, what the doctors think about it, what actually causes joint noises, what the doctors do about it, what the doctors should do about it, and what the patient should do about joint noises. I fall back on a tremendous amount of experience. And again, there may be many people on this episode who have not heard me before, not listened to any other episodes on this podcast. So I must remind you that I really have a lot of experience, both surgical and non-surgical experience regarding this problem. I performed over 2,000 TMJ surgeries, open joint surgeries, and through the arthroscope surgeries on this joint until about 14 years ago, at which point I took a different track to do my own research on why there was so much confusion about TMD, TMJ. And then over the past 12 to 14 years, had an increasing amount of experience with my discoveries and treating patients non-surgically for TMD, TMJ. All told, I've probably done roughly 10,000 consultations with TMD, TMD patients who have the multiple symptoms of this problem. Not all of them went through treatment, but that's why I can pretty much construct about how many patients I have done consultations with, because I have personally successfully treated around 4,000, 4,500 patients non-surgically and 2,000 patients surgically. So that's 6,500 patients, and about 2/3 of the patients that I have done consultations with have carried through treatment, both surgical and non-surgical. That makes about 10,000 consultations. So with that alone, I have a little bit of experience regarding this problem, and certainly the vast majority of those patients came in with some kind of history of joint TMJ joint noise. All right, with that as a background, what do patients think about this problem? Well, for the most part, they are very concerned when their joint starts making noise. In the earlier years, it's very common. It's so common, I almost expect it and can trace it back. Even when I see a patient who has had TMD symptoms for 30 or 40 years, you can almost count on the fact that the way in their earlier years, in their mid or late adolescence or early 20s, they experienced some type of clicking of the temporomandibular joint, usually just clicking, and most of them report non-painful clicking, click, click, click. And then if it's ignored long enough, they start to develop other symptoms, and then they start getting sent in circles trying to figure out why these symptoms are occurring, misdiagnosed, misdirected, mistreated symptoms, etc. But what the patients think about it is they have no idea why their joint is making these kinds of noises. And that they're very concerned about it in some cases, and in the early adolescence, they're not, because it doesn't create any pain or other significant symptom that they're aware of. Now, what the doctors think about it is what they are either told or trained in dental school or beyond about the importance of joint noises. Frankly speaking, joint noises are not important to the doctor. They're not important. Now, there are a group of healthcare practitioners in the dental profession who want to make a complicated deal out of joint noises when it comes to the temporomandibular joint. And they hang a stethoscope around their neck and pretend they're Dr. Kildare, and they go into a 2-hour consultation with the patient and study the joint noises with a stethoscope as to the fact that it might make a difference, which it doesn't. It makes no difference what kind of joint noise is occurring within the joint itself. And of course, anyone who has experience with more than just a few TMD patients will know that the noises vary significantly. We'll explain in a minute what the noises are created by in various ways. But the point is, it isn't effective, certainly not necessary, and the drama is not appreciated to make a big deal out of hauling out a stethoscope and listening to the joint noise, because you're not going to learn anything significant to either diagnose or treat the problem. There is nothing about any of the joint noises that is going to help you, the doctor, in a consultation, determine either what the diagnosis is or what the appropriate treatment should be. So the take-home message is, don't make a big deal out of joint noises. So now, so there are some doctors who think it's a big, complicated problem, which it's not. Now, what actually causes joint noises? Well, that varies. In the early stages, it's nothing more than the partial dislocation of the meniscus or disc, and the condylar head slipping over one of the edges of the biconcave surface of the disc itself. So let me anatomically go and explain what I mean by biconcave disc, okay? You have a socket, glenoid fossa, and a condylar head with the meniscus in between. In a healthy joint, that meniscus should move a little bit and silently as the condyle first rotates the first half of opening, and then translates the last half of opening. Again, the first half is a rotation, which usually brings the patient up to around 25 millimeters on average. And the last opening of the mandible is a translation down the eminence, which allows the mandible to open the last half, which is, generally speaking, another 25 millimeters. So on average, male, female, everybody's a little different. The average opening is on a healthy joint is 50, 55 millimeters. And if you're only rotating, you're only going to get open to 20, 25 millimeters. If you can't translate, you're not going to get open all the way. By the way, that's called a closed lock. But the point is, that is the normal motion of the condyle, and in between the condyle and the fossa is a meniscus biconcave, meaning the upper surface, the lower surface is a concave surface, and the upper surface is a concave surface with excessive margins on either end. So it's like if you take two bowls, if you took two bowls and set them on top of one another, but at like that, you'd have a biconcave surface. In any case, what happens is the condyle slips over the edge and will make a click. At that point, the meniscus may not be very loose, but as time goes on, it gets more loose. It gets looser as time goes on because chronic inflammation within the joint causes the attachments to the meniscus to get loose, and it starts to loosen up, and instead of moving just slightly, it starts to move greatly, and when it moves way out in front of the fossa, then the condyle bumps into it and will partially push it forward, and then it'll click back. Usually that's considered and thought of as a pop, and it's louder, and quite frequently it is associated with some pain. So the click and the pop, and then you can get into the crunches. That is, the crunchy sound is when you start to get significant degeneration of the surfaces of both the glenoid fossa and the condylar head, and you start getting bone loss, especially in the condylar head. Instead of being round, it flattens out. You can actually see these kinds of changes on a Panorex, and very unusual surfaces. They're not consistent anymore, and you start to hear these crunchy sounds or Rice Krispie sounds coming from the joint. It makes no difference at all what the joint noise is doing. I mean, they're different noises. You can't make any judgments from the noise itself. I think I made that clear. So what should the doctor do? What should the doctor do about joint noises? Well, number one, he should reaffirm to the patient that a noise is a sign. It can be a sign or a symptom, but it is a sign that there is problems within the joint. But the noise itself is not diagnostic. So that's what the doctor should do. And he doesn't need a stethoscope to do it. But he should reassure the patient that, yes, that indicates there's a problem and that more information needs to be gathered about the joint itself with an X-ray, which hopefully you will have. You don't need a 3D CT necessarily, although it's great technology. Panorex will do. And a very simple physical examination to find out how much opening is there, which will determine how well you know the joint is performing as far as rotation and translation, which I explained. You will be able to determine intraorally whether there's evidence of bruxism, either abrasion, attrition of the tooth surfaces, or more importantly, whether there are palatal tori or lingual tori or lateral exostoses on the mandible and or maxilla, which indicates bruxism. Tori, lingual tori, palatal tori, lateral exostosis, and the maxilla and mandible are definite indicators that patient is bruxing. Why does bone grow like that? Well, that's a question I've explained many times before. It has to do with how bone grows, under what stresses bone grows. But bruxing on the teeth will stimulate the bone to be laid down underneath the periosteum, and actually over a period of time, you get sometimes relatively large tori, depending on the exact stresses placed on the adjacent teeth. So again, what should the doctor do about it? He should reassure his patients that it is not normal, but when he does hear noise and the patient hears noises from the temporomandibular joint, they need to highly consider the fact that the joint itself is breaking down. So what should the doctors do about the noises? They should document that there are noises in the joint and then continue on with the rest of their examination. The main part of the examination, besides an intraoral examination, how much the opening is, interincisal distance between 3 millimeters. I've seen it as low as 5 millimeters. Patient can't get open beyond 5 millimeters, all the way up to, saw one yesterday. It surprised me, 70 millimeter opening, interincisal distance. But the primary gold standard to determine whether the patient has actually TMD, which is nothing more, nothing less than inflammation within the joint, which indeed is the common denominator and causes the damage within the joint. Chronic inflammation causes the damage within the joint. And chronic inflammation is developed because of three occurrences: bruxism, acute trauma, and functional malocclusion. But the common denominator is chronic inflammation, and to test whether the joint has chronic inflammation, you need nothing more than to have the patient open widely, put your fingers in the glenoid fossa depression firmly, and have them bite down rapidly on their posterior teeth like they normally do, quickly, once. But if you push and they close and it hurts, the joint's inflamed. If you push and they close and it doesn't hurt, it's highly likely the joint is not inflamed. Although on some patients, on rare patients, their tolerance for pain may be such that you don't get that reaction. I primarily see it in males, primarily males. They have all the other symptoms. They have all the other history. They may be damaging. They may have abrasion and attrition to their teeth. It's significant. You know they're bruxing. You know they have headaches and all the other symptoms that go with it, but you can push on their joints and they do not respond like the vast, vast majority of patients do. Just give you a little warning on that one. So what should the doctors do about noises within the joint? They should pretty much ignore them. Just ignore them, because it's not going to help them to determine either the diagnosis or the proper treatment. That is for sure. It is an indicator. It's an indicator there's something wrong, but you need much more information. And you need to reassure the patient that there's more to it, definitely more to it than just noise. And on occasion, you'll run into mom who brings their daughter in at age 16, and that's all she has is a clicking joint. That's all. There aren't any headaches. There aren't any earaches. There's no neck pain, no jaw pain, no tinnitus, but a clicking joint. At which point, I will usually tell the parent and the child, because it usually is an adolescent who comes in like that, that there potentially is a problem, but I do not recommend any treatment at this time unless other symptoms show up: headache, earache, jaw pain, neck pain, etc. And the mother is very appreciative and knowledgeable now that when Sally comes in with increasing numbers of headaches a year or two later, that she knows, oh, now it's starting to get symptoms. Now is a good time to treat it. Because delaying treatment does not, at that part of it, does not make any significant difference in the ultimate outcome. Although you could make a case to treat it prophylactically, I personally do not feel that is necessary because of this one fact. I know many, many patients who have noisy joints, clicking joints for years, decades, but they have no symptoms. They have none of the other symptoms. So you don't necessarily need to treat too early. And I can't really make a case for prophylactically treating just joint noise, which again would usually just be a click. All right. And then finally, what should the patients do about this? The patients just need to be reassured, and the patients need to do nothing other than to give you the rest of their history, to run down the symptom list to find out what other symptoms they may have, do your review of the X-ray information, review of your physical examination, confirm your diagnosis, which is nothing more than a series of symptoms connected to positive finding for inflammation within the joint. You have made the diagnosis, at which point then you can go forward with treatment. Proper treatment being non-surgical disocclusion of the posterior teeth according to a protocol, which allows the inflammation to decrease over the long haul. So that's what I have to say about joint noises. There are many different ways I could have approached that, but I think the way that I did, which was, what do the patients think about it? What do the doctors think about it? What the doctors should do or not do, I think is a very good way to dissect the problem so it's understandable. With that said, I encourage anyone who would like to debate the issue to contact me for a professional debate. Please bring your scientific data with you if you'd like to do that. I can be reached at tony@tmjservices.net. If you'd like to learn more about how to properly treat TMD simply, you do not need to be a TMD specialist to treat TMD because it is a quite simple procedure and you get significant results and predictable results as long as the patient will follow the protocol. If you want to learn more about that, much more information can be seen at www.urbanektmj.com. Urbanektmj.com. I look forward to the next time we visit on the podcast. I always appreciate those who view, and apparently we have a lot of people increasing the view of these podcasts. Until next time, I am Tony Urbanek, and this is TMD Demystified.